Okay. So we'll start the session for the day. Okay. A warm welcome to all the faculties and delegates to yet another session of rapid review series and exam preparation for the final year BDS students, hosted by Azizia College of Dental Sciences and Research, Kollam, in collaboration with Association of Stomatologists and Maxillofacial Imagologists of Kerala, ASMIC. So we have the yet another session with warm welcome to all the faculty students to yet another session of rapid review series and exam preparation for final year BDS students. So we have yet another
Ma'am, you're not audible. Ma'am? Sorry, your voice is breaking and you're not audible.
Madam, ഒന്ന് log out ചെയ്തിട്ട് ഒന്നും കൂടെ കേറിയാലോ വാണി madam?
എന്ത് പറ്റി?
Voice break ആവുകയാണ്, continuous ആയിട്ട് കേൾക്കാൻ വയ്യ.
But അല്ല എന്റേത് ബ്രേക്ക് ആവുന്നുണ്ടോ?
ഇപ്പൊ കുഴപ്പമില്ല.
അല്ല ഞാൻ ഇതുവരെ സ്റ്റാർട്ട് ചെയ്തില്ലായിരുന്നു.
Okay, fine. Okay.
Actually ഒരു ഇൻട്രൊഡക്ഷൻ കൊടുക്കുന്നുണ്ടായിരുന്നല്ലോ. So I am not sure whether I can start or not.
ആര്യ? മാം ഞാനിപ്പോ അപ്ഡേറ്റ് ചെയ്യാമേ സ്റ്റാർട്ട് ചെയ്യണമെന്നുള്ളത്.
Oh, sure.
Hello, Dr. Vani.
Hello, ma'am. Vani ma'am. Sorry for the inconvenience. You can start the session now, ma'am. Thank you.
Okay, sure. A very good evening, everyone. So hope you all had a beautiful day. So let's begin the session. And I sincerely thank Assisia Dental College and ASMIC for providing such a platform to interact with you all. So today my topic is mainly based on recent advanced imaging technologies highlighting digital imaging, CBCT, CT, MRI, and ultrasonography. The major thing is the questions from this area is comparatively limited when it comes to undergraduate level. But still, yes, digital imaging and CBCT recently questions, especially CBCT, recently questions are coming in examinations. Digital imaging, though, anyway, it is given a great importance in the exam. Okay, so let's go through each topic, highlighting what all or how you have to present such question or how you have to present your answer for the questions. Okay, first we'll come up with digital imaging. So the probable questions, the previous asked questions were image receptors in digital radiography, including CCD, highlighting CCD, CMOS, PSP, etc. So that was repeatedly asked in KUHAS. So yeah, either it can come up as an essay to image receptors as an essay in digital radiography, or individually CCD, CMOS, or PSP. The principle can be asked as your short note. Then advantages of digital radiography was asked as a short note. Then comparing intraoral digital radiography with conventional film radiography. And then RVG, radiovisuography, was asked as a short note. And as a bouncer, not yet asked, but still, you may get a question from digital subtraction radiography, or a part of digital subtraction radiography you can include at the end of your question containing digital radiography, because it can be added as an added point in your answer. So first, coming to image receptors in digital radiography. Yes, you all know digital image mainly it's analog to digital conversion. So if such a question asks, you can give a beautiful introduction like how digital imaging works as compared to conventional radiography, highlighting analog to digital conversion. Okay, so what is analog to digital conversion? In digital imaging, basically, whatever may be the principle or whatever may be the detector that we use, the end result is, or the output is coming as an electrical signal or as voltage. Okay, they are read in different fashions, and then they are connected into a numerical format, or they are digitized. Now, the numerical format is ultimately given shades of gray or assigned shades of gray, and we can visualize it as an image in a computer. So that's how digital imaging works. So when such question is asked, give a short introduction of how digital radiography is, or a basic outline of digital radiography. Okay, highlighting the image receptors. So the digital image receptors, you all know, broadly classified into solid state detectors and photostimulable phosphor technology. Under solid state detectors, we have charge coupled device, complementary metal oxide semiconductors, and flat panel detectors. Okay, now sorry. So after that, we should highlight each and every image receptor. For example, CCD. So pictorial representation is very important. So these kind of pictures are you can easily highlight and draw. So you all know CCD, how it works, right? Basically, it consists of a silicon pixel element, okay, and with a scintillating material. So as you all know, the scintillator and fiber optics convert it into visible, the X-rays into visible light, which are taken up by the silicon transistor element, and then electrons are released. Once they take up the energy, the electrons get held up, or the density of the electrons trapped within the electron well is correspondingly to the density of the X-rays falling on it. Then they are fed to analog to digital converter, ADC converter. The voltage is read in a bucket brigade fashion in CCD. So that is the main key highlight point that you need to add. Even if CCD is asked as a short note also, then also please highlight. Initially, you write upon digital, a basic, small sentence about digital imaging, then highlight that it is a solid state detector. Then write the expansion of CCD. Okay, that is also very important. And then you go into explaining with pictures, go into explaining how it works. You should highlight the bucket brigade fashion of reading of the voltages in CCD. That is very important. Ultimately, the data is fed to an ADC, and then after the converting into a digital format, they are assigned shades of gray and visualized in a computer. Okay, so that is how CCD works. As compared to CCD, CMOS, you all know, individual pixel elements are read or voltages are read. Okay, because in each and every pixel, they have an active pixel sensor. So you should be highlighting that point when you talk about CMOS. You all know CMOS is complementary metal oxide semiconductors. So that expansion of each and every short form is very important when you start your question. Okay. Then PSP, again, a very different technology as compared to CCD and CMOS. So when it comes to PSP, it's phosphostimulable phosphor. So especially the phosphor plate is europium dope fluorohalide crystals. So how this picture is very unique. You know, it's very easy to understand and very easy for you to put it in your exam paper. So you can see how the ions go up from the valence band. When they go up from the valence band towards the conduction band, how they get trapped in the F centers. And once the plate is exposed, how they come back to their normal state, releasing energy in the green spectrum, which is detected as a voltage signal. And then these are getting converted into digital format and how they come up as image. So image receptors in digital radiography highlight on after a brief introduction, highlight on how the digital image receptors are classified. Then you should be putting a sincere effort highlighting the principle, the working principle of each and every receptor with pictorial representation. After that, you can add a note on the indications or especially highlighting the advantages and limitations when it comes to digital radiography. So if it is an essay question, this much should be added thoroughly. If it's a short essay, depending upon your time, you can put up the advantage and disadvantage. Otherwise, try to concentrate on the image receptors as such. With a small introduction, start with the image receptors, how each and every image receptor works. The working principle with picture is very important. Then only you will be receiving marks. In essay, you can put as for an added mark, you can put you can add a note on digital subtraction radiography also. Okay. So next is how I just put a small thing on how ADC, that is analog to digital conversion, works. You all know in 2 steps. One is sampling and quantization. So that also in essay, you can highlight these steps. Okay, where how the small range of voltages are grouped together as a single value, that is called sampling. So sampling is done in a bucket brigade fashion in CCD, but individual pixel voltages are read in CMOS. That is the difference. Quantization, each sample signal is assigned a value, a number. So that is what is quantization. That is how an analog is converted into a digital value. Okay. Now, the next questions were on advantages of digital radiography, which has come up as a short note in Koha's examination. So here, you have to compare and write the most of the points when it comes to conventional radiography. Okay, so compare all your advantages of digital radiography with conventional radiography, like how you can avoid, processing, then how you can enhance the images. Those points should be highlighted, because digital radiography mainly, there are a hell lot of advantages, but still the key highlight point should be how processing is avoided, how you can repeatedly enhance the image, or even you can reduce the wastage, because in conventional radiography, lot of wastage is happening, or a lot of waste. So that can be avoided when it comes to digital radiography, how you can store them, how you can share them with different clinicians. So those kinds of things should be highlighted when it comes to advantages of digital radiography, which has come up as a short note. Then comparing intraoral digital radiography with conventional film radiography. So that also has come up with a short note. A beautiful tabular format is given in White and Farrow in that chapter of digital imaging. So there, a beautiful comparison of conventional films with intraoral digital radiography is given. Under each heading, under how the receptors are. You all know for conventional films, the receptors are called as films, whereas digital radiography, we call them sensors. Okay, so from that point onwards, you can highlight, okay, how intraoral digital radiography is compared with a conventional film radiography. You can highlight under each heading and put it as a tabular format. Okay, as a table, that will be more, it will be more easy for the examiner to understand, and you can highlight the points accordingly inside a tabular format. So if such question comes, it is better to always put up in a tabular format. Then one time in 2023 or something, radiovisuography was asked. So radiovisuography was the first terminology when it comes to digital imaging. So that was developed, the concept was introduced by Dr. Moyen, who developed a prototype digital radiography system that he named radiovisuography. So radiovisuography has three parts. Radio means where the sensor is exposed to the X-rays. Then visio means the output voltage signal is converted to the digital format and displayed in a shades of gray in a monitor. Graphy, how you are storing the data, enhancing it, or you can use it for printing, etc. So that is how radiovisuography works. And that is why Dr. Moyen introduced the term radiovisuography. So the principle of radiovisuography is the same as that of CCD. So when a question like this comes, you can put it under digital imaging only, highlighting how a digital imaging works, then highlight the principle of CCD, because the principle of radiovisuography is the same as that of CCD. So such answer should be highlighted like this. Try to include the point like what is radiovisuography. That is very important. Now, as I told you, digital subtraction radiography was previously not asked in any of the question papers, but still, you should just have an idea. In essay questions in digital imaging, you can put it as a small note at the end that can fetch you more marks. Okay, so like, digital subtraction radiography, you all would be knowing. We take two digital radiographs at different times and then subtract them or cancel out them with each other. So the main advantage is we are cancelling out the complex anatomical background. So whatever change, whether after a surgery, whether there is an improvement in the bone support, all these things you can analyze with digital subtraction radiography. Okay, when there is any gain, that is shown as a brighter area. When there is any loss, it is shown as a dark area. So you can put this also as an advantage or image enhancements in digital radiography also. Under that heading also, you can add a note of digital subtraction radiography. So this is just a picture showing how previous image soon after extraction, that is in image A, then 1 month later, and after subtraction, you can see how certain areas are bright, showing bone deposition, and black areas showing bone loss or bone resorption. Okay, so that's how digital subtraction radiography works. So these were the probable questions that were asked under digital radiography, or the most expected questions from digital radiography. Now moving on to CBCT. So currently this is a very important topic. So in past few years, all the question papers, at least a question from CBCT is expected. Okay, so when it comes to CBCT, it is mainly a cone beam computer tomography. From the term itself, you get a lot of information. You're using a cone beam. It's a computer tomography. So computer algorithms you're using. And T for tomography, where slices, images are acquired in slices. So that is a basic information that you get from the term CBCT. Okay. So the probable questions that were asked were as a small MCQ, shape of the X-ray beam in CBCT. I told you it is cone shaped. Okay. Then the other questions were CBCT imaging as such, or CBCT indications and advantages as a short note. And another was limitations of CBCT was not asked, but that may also, that also could be a probable question. Artifacts, I doubt it. There are artifacts in CBCT. So that is the other part that we are not covering today. But artifacts in CBCT, I guess for UG level, they may not be. Mostly they would be asking indications, advantages, and maybe limitations. Okay, even if a general question as CBCT imaging is asked, you need to highlight under these headings a small introduction of CBCT. What is CBCT? Then what is the principle behind CBCT? What is FOV? So what is FOV? It is field of view. Okay, then indications, advantages, and limitations. These many headings should be covered even if it is a short note. So introduction, you can keep it brief with just one sentence. And principal also try to put it as a flow chart. So easy to write it as a flow chart. Every time, especially advanced imaging modalities, always try to highlight the, the working principle, better to put it as a flow chart. It is easy for you to remember, easy for the examiner to understand that you know the answer. You can highlight the points then and there. Okay, when you put it as a paragraph, it is very tough to read through, and you as well as examiner may miss the highlighted points. Okay. So principle, very simply just understand there is a rotating gantry with X-ray source on one end, and it's an area detector in CBCT. When it comes to CET, it is a linear or line detector. That is the basic difference between CT and CBCT. So when I'm discussing this, I'll just add a few points on CT also, because comparing and learning both is quite easy. So in CBCT, we are using a cone-shaped beam. CT, we are using a fan-shaped beam. So that is a highlight. The next point is X-ray source, obviously both sides it is there. Then in just whenever it comes, CBCT is there, whenever that question comes, imagine your OPG machine, which you are quite familiar with. In many of your institutions, CBCT machine also would be available, but still it's very easy to understand the principle by imagining the OPG machine. Okay, so one side you have the X-ray source, the other side you have the detector. So here that it is an area detector in CBCT, whereas in CT it is a linear or line detector. Okay, now the X-ray beam or the divergent cone-shaped or pyramidal beam was passed through the area of interest, and the attenuated beam is projected onto the detector. So the entire series of images that you get after one rotation of 180 to 360 degree rotation is called as the projection data. So what you're getting soon after the imaging is a raw or basis data, which undergoes a lot of reconstruction. It undergoes primary as well as secondary reconstruction. So under primary reconstruction, only the 3 orthogonal plane images are received, like axial, coronal, and sagittal. At the end of secondary reconstruction, you get in all other planes. Okay, so that is a highlight. Like non-orthogonal planes are received, or the images are received in secondary reconstruction, and later you can view the image. So in the CBCT, the advantage is it's a volumetric information is what we are getting at the end of one single rotation. Whereas in CT, the problem is it is a line or linear detector, right? It is not an area detector. So because of that, every time you're just getting one single slice kind of. After one rotation, you're just getting one slice. Next rotation, again, you're getting one slice kind of. Okay. Whereas in CBCT, the entire volumetric data you receive in one single rotation. So that is an advantage of CBCT as compared to CT. Obviously, CT is more advantageous, and but still CBCT has a lot of specific indications, and for us it is very important. Okay, you have to concentrate and highlight the field of view, because this is a very important advantage that we are getting in CBCT as compared to CT, because CT always covers a large area, large FOV, whereas CBCT, you can restrict the FOV. You have a large FOV, a medium one, a restricted view, or a focused view, etc. Thereby, you can reduce the area of exposure of the patient. And then indications, I've just put it like this, but I'm not going to go through it. You need to highlight each and every department. Okay, whenever you write CBCT indications, think about each and every department in your college, whichever branches you have learned. Okay, so each every department, think, okay, surgery. Okay, then mostly dealing with any cystic lesion, the extension of the lesion. Okay, not just the 2-dimensional, but a 3-dimensional extension you will get in CBCT. Any cyst, any tumor, then impacted teeth. The position of the impacted teeth, whether the root is curved, whether the root is very in close proximity to any important anatomical area. It may be canine, it may be a third molar, anything. Okay, and then implant planning. So implants, both the quantity as well as the quality, you can evaluate in CBCT. Even you can do a virtual implant planning. Then changes in the temporomandibular joint, osseous changes, especially because CBCT is not advised in soft tissue imaging. Then different departments, endodontics, you can say altered root canal morphology, any missed canals or accessory canals can be visualized by CBCT with the help of CBCT. The extent of periapical lesions, then in periodontics, the extent of bone loss. Okay, so those things, even in maxillofacial trauma, very important advantages that we have with CBCT. So all these things you need to highlight when it comes to indication. Advantages I told you already. Every time when you highlight the advantage, try to highlight it as compared to CT. Okay, because we have a rapid scan time as compared to CT. Obviously, we can choose a FOV. Okay, then image is very much accurate. We are getting a volumetric data. So you can slice the image not just in the 3 orthogonal planes, but also in the non-orthogonal planes. Very much reduction in patient radiation dose as compared to CT. So those points should be highlighted. And another thing is a user-friendly software is there, and then we can accommodate the CBCT machine even in a dental office setting. Whereas a CT machine, you cannot do that. You need a lot of infrastructure to install a CT machine. So this, as compared to CT, is more economical, comfortable, and safe. So these areas should be highlighted when you write the advantage. Similarly, disadvantage, I already mentioned, always try to highlight that CBCT is not indicated for soft tissue viewing. That is a very important point. Then, as compared to conventional dental or panoramic radiography, obviously the dosage is high. You can talk about the artifacts, poor soft tissue contrast, as I said, and then maybe motion-related artifacts, etc. So these are the disadvantages that you should highlight. Okay. So CT, yes, CT for under KUHAS, CT, MRI, ultrasound were not asked in previous year questions. But in other universities, yes, they have asked. Maybe indication, advantage, and disadvantage is what they have highlighted always. So these are the probable areas under CT where you can expect maybe indications of CT, advantages and disadvantages. And if at all principle you need to write, there are, see, when it comes to CT, the principle is quite vast. You have a lot of generations to write and everything, how it developed, so many things to be written. But for your level, just highlight like this. When it comes to working principle, as I told you, comparing with CBCT, you know, it is a fan-shaped beam. It's a large FOV that will be covering because it's a fan-shaped beam. You can see in the picture image how it is, okay? If possible, you can draw that picture. As I told you, it's a line detector. Okay, so always the images that you get with each rotation, it is like slicing. Okay, just simply like this, you can highlight the working principle. That is, after passing through the patient, the fan-shaped beam passing through the patient, the attenuated X-ray beam reaches the linear detector. Okay, then each pixel in the detector, there is a voltage that is developed that is corresponding to the amount of radiation reaching that area. That again, quite similar to digital imaging, it's assigned a CT number, then assigned a shade of gray by the process called windowing. And then you can even develop a 3-dimensional image from the 2D slices by interpolation. Okay, so in CT, another important thing to highlight it, it has 2 important windows, a hard tissue window and a soft tissue window. Okay, so that is a very important advantage of CT as compared to CBCT. So even soft tissues can be, when you put it in soft tissue window, soft tissue lesions can also be highlighted in CT. Okay. Indications mainly you can describe, like, you know, to describe or to detect the extension of the lesions, if there is any CA or anything, any bony involvement. So especially for a hard tissue pathology, CT is very much indicated. Then in maxillofacial trauma, cyst, tumors, their extension, involvement of vital structures, pathologies in facial bones, any other pathologies in facial bones, TMJ, bony pathologies of TMJ, sinus and salivary gland pathologies, if you put it under soft tissue window, salivary gland pathologies can also be visualized in CT. So these are the advantages, because why CT and not MRI for salivary gland pathology is mainly CT, at least we can differentiate, it's tough to differentiate, but still in soft tissue window, you can differentiate the lesions in the salivary glands. But MRI, benign and malignant lesions of the salivary glands or any other benign and malignant tumors cannot be well differentiated using MRI. So it's always better to go for a CT with a soft tissue window. You can also use contrast enhanced CT imaging. That is also possible. Then you can add a brief note, recent advances in CT. If it's just a short note, you can just say what is CT scan, who developed it. Then just go through basic or 2-3 lines on the principle. Highlight indications, advantages, and limitations, because that is the area you would be expected to answer rather than the principle. Okay, just a brief note on principle, just to make sure that you have an idea about how the CT or the MRI works. Okay, only that is sufficient, but highlight on indications, advantages, and limitations. Okay. Then advantages, as I told you, all 3 orthogonal sections only can be received. Okay, 3D reconstruction is possible. Hard and soft tissue windows are available. You can manipulate and enhance the images, and contrast enhancement is possible. Whereas disadvantage, you all know, very high radiation, very expensive, elaborate facilities are needed to set up a CT machine, and metallic objects can cause artifacts. So coming to MRI. MRI, a few MCQs that were seen in the question papers were like soft tissues of TMJ, like, disc derangement disorders or internal derangement of TMJ disc. All these are best diagnosed using MRI. So especially MRI is for a soft tissue visualization. The principle of MRI is quite complicated for your level. So mainly you should just understand, like, it is based on the natural magnetism of our human body. So we have a lot of water in our body. Okay, we have a lot of water in our body, and we have H+ ions, which are the protons. Okay, that is a proton density in our body. Okay, so just highlight in such a way that these protons are positively charged. They can rotate. That is called spin of the protons. So when a charged body moves, it generates some electric current. Okay, so when there is an electric current, obviously there is a magnetic field around it. So all the protons in our body, there are different ions in our body. In all the ions in the body with a spin, whichever is moving, all those have a small magnetic field around them. Okay, since water is abundant in our body, we are mainly highlighting H+ ions and considering them or utilizing the proton density of H+ ions for imaging. That is what is happening in MRI. So we have a small magnetic field around each proton or the H+ ions in the body. And usually when our body is there, just like that, there is no net magnetization. Everything is aligned in different directions so that their charges cancel against, the magnetic field cancel against each other. So there is no net magnetization. But when you put the patients inside the MRI machine, an external magnetic field is applied. So corresponding to that external magnetic field, a net magnetization in a transverse direction is produced. But we can't, we can't measure the transverse magnetization. So for that, we apply a radio frequency signal from exterior. Okay, so that radio frequency pulses again changes the alignment of this proton alignment, causing a net magnetization in the longitudinal direction. So once the radio frequency pulses are stopped or switched off, these protons try to come back or they relax. Okay, based on that relaxation, you have T1 and T2 relaxation time, and that is how the return signals are how they are received by the MRI machine, and that is how we visualize the image. So by T1 relaxation time and there is T2 relaxation time, I'm not highlighting or going into the details of it. So by T1 relaxation time, always the T1 weighted images are best suited to visualize the anatomy where fat appears brighter. So in MRI, unlike the other imaging modalities, it is highlighting soft tissue. So obviously soft tissues, especially fat, appear brighter or white in MRI. Okay, in T1 weighted images, whereas in T2 weighted images are mainly for pathologies, wherever there is a lot of fluid in inflammation or any other lesion, the fluid content or the vascular content is high. In that times, whenever there is a pathology due to inflammation, causing inflammation, T2 weighted images are highlighted. So obviously they appear brighter. Water appears brighter in T2 weighted images. So that is how MRI works. The working principle is complicated, but this is a small gist how you can put it if at all a short note comes from MRI. Kindly highlight, or the key points should be indications, Contraindications, advantages and disadvantages. Indications are these, especially soft tissue pathology, disc derangement disorders of TMJ, okay, salivary gland pathology, any lesion with a neuromuscular involvement, even CA, and any neurological disorders, muscular involvement disorders, vascular lesions, intracranial pathologies, lymph nodes, everything can be highlighted in or visualized by MRI imaging. Contraindications, you all would be quite aware. Claustrophobic patients with cardiac pacemaker, cochlear implants, those who are allergic to contrast media used in MRI, all these things, or for all those, it's contraindicated. Advantages, non-ionizing radiation, non-invasive, except when you're not using contrast medium. Then excellent soft tissue contrast. You can do image enhancements and manipulations, whereas disadvantage, highly costly. The maintenance and operation is difficult, very much operator sensitive. Then long scanning time. The metallic things can cause artifacts, and we cannot differentiate, as I told you previously, differentiating between a benign and malignant lesion is quite tough when it comes to MRI. Okay, so these things should be highlighted. Finally, ultrasonography. So working principle of ultrasonography is very easy. Okay, so mainly the ultrasound waves are generated by piezoelectric effect. So the piezoelectric material, when they are just, when AC current is given to it, they get mechanically altered, generating mechanical waves, that is ultrasound waves. So using the transducer, these waves are sent to the target organ. So when they reach any two tissue interface with different acoustic impedance, they undergo both reflection, refraction, or absorption. So after reflection, the echo, the coming back signal is called as echo, that is taken up, that comes back, and that is received by the same transducer. So in ultrasonography, the thing is only 0.1% of the time, the piezoelectric crystal is emitting ultrasound waves, whereas the rest of all the time, the 99.9% of the time, it is like it is only receiving the echoes. It is just listening to the echoes. So the time delay for the echoes to reach back, you can calculate the depth of the organ or the particular tissue that you are viewing or visualizing. And then that electrical, then when it comes back, the transducer converts it into an electrical signal. Those are again fed to the processor and they are visualized in a monitor. Indications, very important indication of ultrasound is, it is best to differentiate between a solid and a cystic lesion. In soft tissue pathology, cervicofacial lymphadenopathy, then organs like tongue, muscles, salivary glands, etc. Then any oral and neck masses, soft tissue masses, space infections, and for vascular lesions, you can use Doppler ultrasound. So there are a lot of, modifications or advancements in all these imaging modalities. So you can highlight that also. So when you write about CT, MRI or ultrasonography, at the end, you can also put a recent advances. For CT, you can write, MDCT. Okay, then dual energy CT. These are all these few recent advancements in CT. Similarly, you can put ultrasonography or Doppler ultrasound, color Doppler, Doppler duplex ultrasound, etc. So many such things are there. So all those things you can just put like small points and highlight your answer. Advantage of ultrasound, non-ionizing radiation, excellent soft tissue imaging, very widely accepted and inexpensive. Then live imaging is what is done in ultrasonography, whereas limitations, it's highly operator dependent. Whenever there is a gas interface between the transducer and the imaging area, very poor contrast would be received and a lot of artifacts can happen and poor heart tissue evaluation in ultrasound. So that finishes this session. Any queries or any doubts or any other areas that you need to highlight, you may put it in the chat box.
Thank you so much, Dr. Vani. First and foremost, my sincere apologies from the start.
No issues, no issues.
The technical glitches. And yes, Dr. Vani has, concised properly and she's well articulated this presentation because this is an ocean. The advanced imaging is like, it's a sea out there that, you have to explain a lot of things, but she's concise and beautifully presented it out for the UG students. I hope this presentation gets well to the UG students as such. If you have any queries and if you have any questions to be asked, you can place it in the chat box. We can move forward to the next session. And Dr. Vani, I request you to stay back because after this Dr. Hima session, we have a certificate to be presented to you. So please wait for the session at the end of the session. Okay.
Sure, sure.
Thank you so much. So Dr. Hima, you there?
Yeah, I'm here. Yeah.
Dr. Vani, can you just stop your
Stop sharing it. Just
I hope right now I'm audible, right?
Yes, Doctor, you're audible.
Yeah, okay. Thank you.
I'll start sharing my screen.
Yes, yes. And before that, I'll introduce Dr. Hima John. Dr. Hima John V. She's currently working as professor in Department of Oral Medicine and Radiology at Anur Dental College and Hospital, Muatupura. She's a right apt person for this topic, where she'll be speaking about orofacial pain, temporomandibular joint and disorders, because she's done her fellowship in orofacial pain, TM disorders and sleep dentistry from Norseman University, USA, and also she's currently doing her mastership also in the same. And she's done her BDS from Oxford Dental College in the year 2005 to 2010, and she's done also her MDS from Vaidehi Institute of Dental Sciences, Bengaluru in the year 2012 to 2015. And under her name, she has a lot of publications as well as national publications. She's also been a faculty of various CDE programs in academic institution and IDA programs. So over to you, Dr. Hima John V, for the presentation.
Thank you, Dr. Shanila. First of all, wonderful presentation by Dr. Vani. So hopefully I can also continue the same path in this presentation too. Students, as you all know, I'm from Anur Dental College. So warm greetings from our whole department. So today I'm going to be talking about orofacial pain and temporomandibular joint disorders. Now, over the years, many questions have been very focused when it comes to this topic. So I've selected a few topics under which you have to know these topics, okay? Because orofacial pain, when you start reading it, you'll feel that it is very, very vast. But there are some selected topics which has always been, asked over the years. Now, as you can see, over the years, orofacial pain, definition of pain, describe the etiology, clinical functions, and management of trigeminal neuralgia has been asked in all these universities, that is KUHAS, Manipal University, Amrita, and Rajiv Gandhi University. And orofacial pain, has every 2 years almost, the question gets repeated for a long essay. So it is definitive question for your exams, okay? Apart from that, temporomandibular joint disorders have also been asked quite sometimes. And diagnosis and management of myofascial pain dysfunction syndrome. Now, these two are the essay type questions which has been asked previously. As a short essay, most of the times it has been medical management of trigeminal neuralgia and burning mouth syndrome. Now, burning mouth syndrome can also be asked as glossodienic. Okay, so you have to be aware of the term glossodienic. Apart from this, TMJ arthritis has been asked as a bouncer probably just once in all the question papers I've gone through, that only in SRMU, Sri Ramachandran University. And Laskin's criteria also has been asked probably once in RGHS, and TENS therapy has been asked twice in Amrita, but it has never been asked under KUHAS. So these are the frequently asked questions under orofacial pain and temporomandibular joint disorders. Now going on to our presentation as such. Now what is pain? I'm sure all of you all are very aware of this particular definition. That is, it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, when a question comes, anything related to pain or trigeminal neuralgia also, always start off your answer with the definition of pain, okay? Next is moving on to the classification. I know orofacial pain classification is very, very vast, but we have no option, but we have to know it, okay? So there are various headings under which you can split it and learn. And when you're learning it, in the Okesen's textbook, it is given as Axis 1, Axis 2. And that is like 2 whole pages. So this is a concise format, okay, which can be reproduced in your papers. So which is easier for you students to write it down and easier to understand also, okay? Because the first part here deals with structures from the tooth as such or related structures. Next is your myofascial pain. Third one is your pain related to your temporomandibular joint, either primarily due to some kind of derangement or due to secondary causes. Next is pain which arises from cranial nerves. Apart from that, when we move on to the fifth one, it is headaches. Okay, under headaches, you have different types of pain, that is migraine, tension type pain, okay, and trigeminal autonomic pains. Then the final one is idiopathic orofacial pain, under which you have your burning mouth syndrome and all that. Now, before you move on to learn about trigeminal neuralgia as such, there is a small concept which I want you all to understand, which when you all are writing your exam, if you can probably, with the help of a diagram, explain it, it will be very beautiful. Now, there is something called as a gateway control theory, which beautifully explains how the pain from your particular tooth or your lip or your tongue reaches our brain. Now, there is something called as large and small nerve fibers, which is present in our nerves. And the signal from these nerves, how does it reach our brain? There is something called as inhibitory interneuron, and there is something called as projection neuron. Now, without any stimulation, the inhibitory interneuron always overpowers the signal of your projection neuron. So therefore, the so-called gate, okay, the gate which lets the pain signal passes is always closed. Okay. So now when there is a non-painful stimulation, like suppose you're holding someone's hand tight or, someone is just probably, squeezing your cheeks, but not painful. So when that happens, what happens is this activates both your projection neuron. At the same time, it also activates your inhibitory interneuron. So what happens is, because your inhibitory interneuron is more powerful here, the pain signal is not being conveyed to the brain. So what happens is in the next, when there is a pain stimulation, like someone is pricking you or you get some kind of a poke. So your small nerve fibers become active. Now, when the small nerve fibers become active, they activate the projection neurons and block your inhibitory interneuron. So because of this, what happens is, you can see when your projection neuron is activated, the pain pathway continues. Okay, the gate is open. So the pain signal, it goes to your pons area, and from there it is reaching your brain. Okay, so if you can, I'm not saying everyone should, to get those small brownie points or extra points while writing your exam, if you can draw the pain pathway, that will be ultimate. Okay, if you cannot, that's no problem, it's okay. Okay, so pain pathway, what happens is, once probably like when I was studying, when I referred papers, it has been asked to draw the pain pathway. That was probably, say, 20 years ago, but in the last 10, 15 years, it has not been asked. So if a question comes, draw the pain pathway and how the pain initiates in your trigeminal nerve, you can probably just, draw probably a nerve starting from your tooth, going up to the pons, and from pons to your hypothalamus and the cortex. If possible, draw. If you cannot draw, no problem at all. Okay, so moving on to our main topic, that is trigeminal neuralgia. So neuralgia is basically a sudden, unilateral, severe, brief, stabbing, recurrent pain in the distribution of one or more branches of the fifth cranial nerve. So basically, this is a disorder which is characterized by lancinating. Lancinating means what? Severe, sharp shooting, like, some electric shock type of pain. Okay, the patient will typically present or tell these particular words. Now, the diagnosis is based primarily on the history of the characteristic pain attacks that are consistent with specific research and clinical criteria. Now, the question can also come as tic douloureux or Fothergill's disease. So, if the question can come like these also. Okay, so the question can come, define pain, classify orofacial pain, and write about Fothergill's disease. Sometimes the question can come like that also. Okay, so that time you're supposed to write about trigeminal neuralgia itself. Next is, trigeminal neuralgia can be mostly of two types. One is classical. Basically, your imaging and your lab test, everything will be unremarkable. That is, the patient will look like he's absolutely fine. The second group is something which is secondary to some kind of underlying disease. It can be probably a tumor or an AV malformation. It could be any of those. So which, develops secondary to some other kind of disease in the body is known as symptomatic trigeminal neuralgia. Now, coming to the epidemiology and demographics, the incidence is about 4 in every 1 lakh, and majority of the cases occur spontaneously, and it has a slight female predominance. And as you can see, the age distribution, it is more commonly seen after the 5th decade of life. Okay, so this is the age distribution of trigeminal neuralgia. Now, as I said before, pain typically consists of lancinating paroxysms. Paroxysm means what? Sudden. Okay, sudden. And it has no typical pattern. Okay, mostly seen in the 2nd and 3rd trigeminal divisions. Right side is more commonly involved, and pain attacks are stereotyped for that particular patient. And there are symptom-free attacks. There are symptom-free period between the attacks, and it is usually a chronic disorder. Most patients will experience pain attacks for years unless it is appropriately treated. Now, the cause is usually unknown unless the patient has a secondary type of trigeminal neuralgia, where there are initiating factors like a compression by a tumor, presence of an amyloid, AV malformation, Pons infarct, or a bony compression of the nerve itself. Now, the diagnosis of your trigeminal neuralgia is basically based on definite criteria. Okay, it was put forth by White and Sweet. You can probably write it as Sweet's criteria. Okay, so when you write a trigeminal neuralgia answer, please mention your diagnostic criteria. Okay, that has to be mentioned when you write about trigeminal neuralgia. Basically, it consists of 5 major clinical features that defines the diagnosis of your trigeminal neuralgia. What are those features? 1, pain is paroxysmal. That is, it is sudden. Okay. Then the pain may be provoked by light touch to the face. That is, there will be presence of something known as trigger zones. I will be explaining it later. Okay. Then the pain is confined to the trigeminal nerve division. Pain is usually almost always unilateral, and clinical sensory examination is normal. That is, no sensory deficit will be present in that particular patient. Okay. So those were the 5 points of your diagnostic criteria, which has to be written when you write your trigeminal neuralgia answer. Now, the pain of the trigeminal neuralgia has some features. Okay, what are they? They are basically paroxysmal attacks, electric shock-like quality, sudden onset, severe in intensity, and patient usually has a very a facial grimace that is typical of that severe pain. Now, the duration can be anything between 1 second or 2 minutes, and it is instantaneous, like a lightning bolt type of sensation. And between the symptoms, between the attacks, they're usually symptom-free. Now, what are trigger zones? Now, trigger zone is basically an area of facial skin or oral mucosa where a low-intensity mechanical stimulation, that is something as light as a small touch itself, triggers the pain. Now, when you write about trigger zones, it will be very beneficial if you can actually just draw a nose and a lips and the alar tragal line and just point, just circle out these areas. That is the alar of the nose, angle of your mouth, and the alar tragal area. So this is the particular area where trigger zones are usually commonly found. Okay. So in the perioral area, this is what I said, alar of the nose, nasolabial fold, angle of the mouth is where it is usually found. Now, 1st division trigger zones are usually rare, but the presence of trigger zones is very, very definitive diagnosis for the presence of trigeminal neuralgia. Now, I told something about the pain being bilateral in some cases. Now, that is usually seen in conditions if the patient has something called as multiple sclerosis. Okay. So in cases of multiple sclerosis, patient might present with bilateral pain presentations. Okay. So when the patient has neuralgic type of symptoms bilaterally, it is more likely to be multiple sclerosis. Okay. Now, diagnostic testing, there is no specific test as such which gives a clear-cut answer that if the patient has this, it is definitive for a trigeminal neuralgia. Most of the time, the diagnosis is usually done by the clinical examination or the history itself, and which adds with the clinical examination, you will arrive at the diagnosis of trigeminal neuralgia. Next is you have to rule out secondary trigeminal neuralgia. That can be done only after you take a MRI and also MRA, that is magnetic resonance with the help of angiogram. Okay, so that is basically the test of choice for trigeminal neuralgia. That is to see if there's any vascular compression of the nerve, or if there is any kind of tumor which is compressing the particular nerve, which is giving rise to these kind of symptoms. Okay. Now the differential diagnosis is vast. Okay. Any type of condition which can lead to severe pain can be your differential diagnosis for trigeminal neuralgia. Now, one interesting thing which you have to remember is once a question has come where for 10 marks, it was differential diagnosis of unilateral pain. Okay. So students, when they get this type of question, they will be initially in a state of shock, like differential diagnosis of unilateral pain, because the question sounds so vague. The first thing you all will think is, my staff didn't teach me this. Okay. So basically, you just have to sit there for a minute and think, everything in dentistry that you learn about pain is a unilateral pain. Okay. So that's how you're supposed to build your answer. Okay. So when you get a question like that, just sit there for a minute, think, and then start answering. Because anything from your pulpitis, your abscess, pulpitis, any type of neuralgia, okay, any type of trigeminal neuralgia, glossopharyngeal neuralgia, postherpetic neuralgia, okay, all this usually is always unilateral. Okay. So when you get a question, sometimes, okay, rarely you might get that kind of question, differential diagnosis of unilateral pain. Okay. So you just have to think and build your answer accordingly. Okay. Now, treatment can be divided into medical and surgical. Now, medical treatment, basically what we do is, whenever we suspect a patient has trigeminal neuralgia or it's a clear-cut case of trigeminal neuralgia, we always start off with anti-epileptic drugs. Okay, that is the cornerstone treatment for your trigeminal neuralgia. Always start off with a minimum dose as possible, then increase the dose as and how, if it is required, or if the patient responds to the minimal dose, that is enough. Okay. And another important points which you're supposed to note down when you prescribe medicines for patients with trigeminal neuralgia is that monitor side effects, monitor levels, and blood tests if indicated. That is, whenever these anti-epileptic drugs are prescribed, most of the times they end up developing anemia. Okay. And Tegretol remains a gold standard. And whenever patient you're suspecting to have trigeminal neuralgia, start off with the basic drugs first. Okay. Now, these are the various types of drugs which could be given for trigeminal neuralgia. Okay. From your anti-epileptic drugs, tricyclic antidepressants, baclofen, opioids, any of these can be started. But usually what we start off with is anti-epileptic drugs. Okay. Next is adverse effects of these anti-epileptic drugs. As you always write for any of your pharmacological drug interactions or adverse effects, nausea, vomiting, headache is seen in this also. Then there will be presence of cognitive changes, sedation, diplopia, dizziness, all that. Okay, you can probably write it as a small point, because why I'm going in detail is around 3 to 4 times medical management of trigeminal neuralgia has been asked separately. Okay, so you will have to write it down a little more in detail when you're writing about a short essay. So that's why adverse effects, different class of drugs, you should know which is used for trigeminal neuralgia. Most common drug that is used is carbamazepine, where we usually start off with a dose of 100 mg as a BD dose, and you can titrate it up to 2400 mg if required, that is. And there are 2 different types, that is immediate release and extended release also. Now, apart from that, we can also try drugs like baclofen, dilantin, lamictal, Neurontin. Okay. Now, this is a drug therapy which could be used for trigeminal neuralgia. That is any drug like gabapentin, baclofen, clonazepam, lamotrigine. Okay, any of these can be used for the treatment of trigeminal neuralgia. Always start with the initial dose and titrate it as and when required. Now, if the patient does not respond to your medical management, or patient was responding for quite some time, and then they started developing resistance, or for some reason, they're not responding to the medications, or in cases where surgical treatment is warranted. In those cases, there is no other option but probably turn for a surgical management. There are various types of surgical management, both percutaneous and open techniques. For an undergraduate point of view, you just have to remember few of these names. Okay, there is something called as microvascular decompression, percutaneous ablative procedures, stereotactic radiosurgery, peripheral ablative procedures, peripheral branch neurectomy, alcohol neurolysis, or even open destructive procedures. You just remember the names of few of these procedures. Okay, that will help. Now, moving on to temporomandibular joint disorders as such. The question has come like define orofacial pain, then classify temporomandibular joint disorders, and write in detail about myofascial pain dysfunction syndrome. Now, when the question comes about classify temporomandibular joint disorders, please remember to include these 4 main headings. That is temporomandibular joint disorders, masticatory muscle disorders, headaches, and pain related to the associated structures of your temporomandibular joint. Okay. And if you can draw the diagram of your temporomandibular joint, that also gives you probably extra brownie points. Okay. So there are various headings under each of these. Most of the times it is almost always it is MPDS that is asked. Okay. And in other universities like your MGR University and all, they have asked TMJ arthritis. Okay. But under KUHAS, it has almost always been MPDS, which has been asked over the years. So moving on to which has been asked over and over again over these years, that is myofascial pain dysfunction syndrome. Now, this is basically a pain that is referred from a localized tender area or a trigger point in a taut band of skeletal muscle. So here we're talking about the masticatory muscles. Now, area to which the pain is referred is called the zone of reference. Sometimes it might be a myofascial pain, but the patient might also complain of either headache or neck pain and all. Okay. Now, these can result from acute injury, but it is usually always over time. That is repeated micro trauma over the period of probably say many years or months, which results in the development of myofascial pain dysfunction syndrome. Now, occlusal abnormalities has been suspected to play a role in the etiology. Laskin has put forward these various criteria, okay, which helps us in determining if the patient has MPDS or not. Now, Laskin's criteria by itself has also been asked as a short note. Okay, so there are 4 points under which you have to write. That is unilateral dull pain in the ear or periauricular or preauricular area, which is worse on awakening. Tenderness, which is present in the masticatory muscles when you palpate them. Limitation or deviation of the mandible on opening. And when you take an OPG or when you do any examination, there is no gross change in your temporomandibular joint. So these are the 4 points, which is commonly called as Laskin's criteria. Okay, that itself might come as a short note. Okay, so it is very important for you to remember those points. Now, etiology can be anything. It can be anything from stress, clenching and grinding of your teeth, which leads to muscle fatigue and spasm. And muscles involved mostly are your lateral pterygoid and masseter muscle. Irregularities in occlusion has been proposed, which could be occlusal interferences, posterior bite collapse, deep bite, overjet, increased overjet, overbite, and all these could lead to parafunctional activity, that is presence of either bruxing or clenching of teeth could be seen in these patients. Now, mouth opening could be restricted, and because of these restricted movements, one set of muscles are, might be acting more. So because of which it leads to overuse of masticatory muscles, and again, which leads to myofascial pain dysfunction syndrome. Treatment in these set of individuals or treatment for your MPDS is basically more or less first is treat emotional and physical components. Conservative non-invasive treatment, that is basically you can probably start off with muscle relaxants and initially reduce the pain, then patient education and information, and educate them about discontinuing their parafunctional habits, self-care and habit reversal. For habit reversal, you might have to give habit breaking appliances also. Okay? And a relatively soft diet is recommended initially. Occlusal adjustments sometimes might be required, and you might require splint therapy also for these kind of patients, and physiotherapy too. Now, disc displacement is, though it is one of the most common day-to-day diagnosis of your temporomandibular joint, or one of the most commonly seen temporomandibular joint disorder, the question as such, surprisingly, has been almost never, you can say, okay, under KUHAS, which was a surprise for me also, because I always thought internal derangement or, this displacement was a very common question. So for completion purpose, I have put this also because you definitely have to know what disc displacement is, okay? So your disc displacement, if a question is given in your exam, always start off your answer by drawing your temporomandibular joint, okay? That is the bony component. That is, you have to draw your condylar head, the articular eminence, then you have to draw your articular disc in between, okay? So just show the normal position of the disc and just draw another diagram with showing the disc in the slightly anterior position, okay? Because anterior disc displacement is one of the most common clinical scenarios which you could come across in your clinical practice, okay? So basically, it results in the anterior medial displacement of your articular disc. Now, effect on function is basically when the patient tries to open the mouth, you can hear that clicking noise, okay? That is one of the most common either presenting symptom, or when you examine the patient, you will be able to feel the presence of a click. Now, one thing you have to remember is there are 3 types of disc displacements which you could come across. That is disc displacement with reduction. With reduction means patient is able to close the mouth. Next is disc displacement without reduction with limited mouth opening, and disc displacement without reduction without limited mouth opening. So these are the probable diagnoses which you could come across for disc displacement. Management is more or less similar like how you managed your MPDS cases, unless it's a gross case which requires surgical intervention. Management is always conservative for your disc displacement, almost same as how we manage patients with MPDS, okay? Next, moving on to the next topic, which has been asked for mostly for your short essays, okay? It can either come as a burning mouth syndrome, or it can be asked as glossodynia also sometimes, okay? Now, basically, this is the oral burning that has no detectable cause. Burning does not follow any anatomical patterns in these patients, and when you examine the patient, the oral cavity will look absolutely fine, okay? So that is the presentation of burning mouth syndrome. Now, the etiology remains unknown. It could be due to your hormonal allergic disorders, salivary gland dysfunction, chronic low-grade trauma, or sometimes, very rarely, psychiatric abnormalities, but that is a debated question, okay? Now, most commonly seen in women, about 10 to 15 are, 10 to 15% are your postmenopausal women who gives a history of burning mouth syndrome, which is usually prevalent for about 3 to 12 years after the menopause. Tongue is the most common site which is involved, followed by your lip and palate. Now, burning sensation or this feeling of burning can be either intermittent or continuous. Now, eating or drinking in some patients relieves the pain. They're usually very apprehensive and anxious because they feel that since nothing is visible, the others are feeling that they're, just making up their problems. Thorough examination and investigation is definitely required for you to come up with the diagnosis of burning mouth syndrome. Now, there are different types of burning mouth syndrome. Where type 1, where no symptoms are present on waking but increases during the day. Second type is symptoms are present on waking and throughout the day. And third type is there is no regular pattern of symptoms. So basically, 3 types of burning mouth syndromes may be seen, okay, in those individuals. Management is basically counseling and reassurance. Why? Because most of the times when you acknowledge that the patient has that kind of a disease itself, they will be relieved. That is more than enough for mild conditions. Now, in severe conditions, drug therapy may have to be started. Most commonly used drug is your amitriptyline. Start off with a minimal dose as possible. I've written here 10 mg, but if you can start off with a 5 mg also, that might be enough for some patients, okay? Topical analgesics could be tried, and alpha-lipoic acid also can be given. Some patients might respond to hormone replacement therapy, but that That is not the standard of care. Okay, that is like, it's not like one shoe fits all. It has to be tried and tested for different types of patients. Next, over the time, what has been asked is, once again, it is not asked under KUHAS, but it has been asked repeatedly in other universities. Okay, and that is basically your transcutaneous electric nerve stimulation. Now, in this situation, what happens is there is something called as, we use alternative low intensity current. Now, if you remember what I had explained in that gate control theory, basically you have your small nerve fibers, which is actively involved in pain perception, or which conducts pain from that particular site to your brain. So this theory, or how this transcutaneous electric nerve stimulation works, is it uses these low intensity current in that particular area where you have pain. So what happens is it competes with the noxious stimuli. So if there is some kind of a stimuli which is producing pain, this particular electric current competes with that current, and when you place it on the patient's area where there is pain, in your temporomandibular joint disorders, we usually place it over the masseter muscle. So what happens is when we place it over the masseter muscle, it is felt as a tingling or vibrating sensation. Okay. So what happens is when this sensation is being produced in that area, the pain is being subdued or masked. Okay. So when this happens, what happens is this tingling sensation or vibration reaches the brain first. So even though the pain stimulus is there, this overtakes it. So when you give a TENS therapy to a patient, they feel much, much better, or there is immediate pain reduction or analgesic effect, which can be seen due to TENS therapy. Now, any of these topical applications which you use for treating your pain conditions, okay, that is, be it topical application of your Wolverin gel, or something which you are commonly familiar with, that is Move gel application for pain. The concept is the same in everything. Basically, you are applying a counter irritant on the painful area. So what happens is when you apply this counter irritant, the pain stimulus is still there, but you're applying some other stimulus which overtakes your pain stimulus. Okay. So when this reaches the brain, it is the pain or the noxious stimuli does not reach the brain, but this irritation or this tingling feeling, or the coolness which you get from applying any type of topical gels is what reaches the brain first. Okay, so this is the mechanism of action of any type of topical application for controlling pain. Okay, so with that, I have very concisely given you all what is required for writing an answer from orofacial pain. Almost always the question has been trigeminal neuralgia. Okay, almost always say, if you take like over the years, 100% of orofacial pain questions, 96% of the time it has always been trigeminal neuralgia. And when you come to temporomandibular joint disorders, again, out of the 100% of the questions, say about 90 to 95% of the time, it has always been classify temporomandibular joint disorders and write about myofascial pain dysfunction syndrome. So these two are the questions which is almost always asked. Okay, so apart from this, you have to know your burning mouth syndrome, which can be asked as a bouncer, and Laskin's criteria. Okay, that can also come as a short note. Apart from this, what you have to know is medical management of trigeminal neuralgia also has been asked many times as a short essay. Okay, so that is also an important topic, which again comes under trigeminal neuralgia. And apart from this, what they could ask is post-herpetic neuralgia, which can be in association with your as a after effect of your viral disorders. Okay, so post-herpetic neuralgia can be asked. It has not been asked till now, but could be asked. Okay, you can expect it as a bouncer. Okay, so with that, I think I come to an end of my presentation. And this is thanks from the OMR team of Anur Dental College. If there are any questions, I'm open for questions.
Thank you, Dr. Hima Janvi, for an enthralling presentation. And yes, we are open to Q&A session right now. The delegates and you can ask your questions regarding the topic. I've not seen any questions rising from the chat box as such so far. Participants, if any questions or any queries regarding either of the topics, that is, we had a topic about orofacial pain and TMJ disorders, as well as advanced imaging. Have any questions to ask? You may please unmute yourself and then the question.
Resource persons are eagerly waiting to clear your doubts.
Okay, there's one question that is raised in the chat box. Okay. If Laskin criteria is asked for 3 marks, all include other than the points of criteria?
Yeah, that's a good question because it is a 3-mark question. Students usually have a habit of writing everything about MPDS. Okay, so usually when we get an answer key from Kuhas when we correct paper, if they have written what is MPDS, okay, if they can at least define or write what MPDS is, write say about 1 or 2 lines maximum defining probably the pain feature of MPDS. Write about Laskin's criteria because that is what has been asked. And apart from that, just say 1 or 2 lines on management. That's enough. Don't write the whole story. Okay? Because when we get from Kuhas, when we get the what's it called?
Answer key.
Answer key. Yeah, answer key also. Mostly it will just be stick to the main point itself. So stick to the main point for a 3-mark question. Don't beat around the bush. Not required. Okay, stick to the main point, probably say 1 or 2 points above it and below it. That's enough for a 3-mark answer. And any question, if you can draw, that is much, much better. Okay, that will fetch you more marks. Any question, if it is, suppose, if it is about, though it is not my topic, it will be taken up later on, about imaging of a temporomandibular joint. If you can just draw each technique, that is enough. Don't sit and write stories because you will waste time. Drawing, it gives us a better picture of what you know and it conveys that you don't know the answer. Stick to the point which is asked, unless it is a main essay. Short note, always stick to the point.
I hope that clears your doubt, Lakshmi. Any other questions? It's been elaborately been discussed both the topics, so there are no doubts as such, I believe, from the participants. So we'll move forward with the certificate presentation. Okay, Dr. Hima, can you just stop your screen share?
Yeah. Sure.
Yes, sir. Okay. Here's to Dr. Vani MH
Yes,
for
thank you.
her clear-cut presentation for the topic of advanced imaging. So here presenting our certificate of appreciation to Dr. Vani MH, being a sporty resource person and Over to you, Vani. And
Thank you so much for giving such a wonderful opportunity. I hope the session was useful. So any queries still we are open, so you can put you can convey the messages to your corresponding staff, and still it can reach us. So thank you so much for the opportunity anyway. It was nice being on this platform.
thank you so much, Dr. Vani.
Thank you.
The next presentation to Hema John V, resource person for the topic, facial pain and TMJ and disorders. Thank you so much, Dr. Hema John V.
Thank you, Doctor, for the opportunity. And thank you, ASMIC and CCR College of Dental Sciences for this wonderful, like this initiative, which they've been doing over the years. So hats off to them, because it really helps a student, to in the last minute, when they're trying to read everything, they might feel jittery. So brushing up like this really helps them prepare better for their exams. And once again, thank you, ASMIC, for giving me this wonderful opportunity, and hope it was of use for our dear students. And again, I think this will be given to the students also. So it will be like a quick review or runner before the exams. Thank you once again.
And Dr. Hema ma'am, it was very nice listening to your session. Yeah, even it's very informative for us also, because I feel next time when we are taking the topic for our UGs, so these points we could highlight now. We could tell them, like, we could convey to them this you should be highlighting in your answers. So that was indeed, you were describing it in a very composed manner, and that was wonderful listening.
Yeah, actually, this is something which I take for because it's a topic which I like. This is something which I take for like 3 to 4 hours. So I found it really difficult to concise it. And when I looked at my watch now, I was glad I finished it in like 40 minutes.
Yeah, you finished it before time. I could say 15 minutes before time. And
that's
both of you, thank you so much for enlightening this day with this beautiful session of both of yours. And thank you to the participants for your eager listening. And if you have any queries or questions, you're free to that is in the WhatsApp group itself. And definitely we will share our the resource persons PPTs also on the WhatsApp group itself. And thank you so much. Have a good evening. Good night.
Thank you very much. Good night.
Thank you all.
Good night.